Live, everyone. Just before we get started, I have a couple of gentle reminders. This session is being recorded, so if you've missed anything along the way, you can always view it on our website under NTF Live. And we welcome your feedback on this session. Please provide your thoughts to us at the link in the chat and be entered to win a copy of Jenn Johnson's book, Nursing Intuition: How to Trust Your Gut, Save Your Sanity, and Survive Your Career. Sounds like a good plan. And now it's my absolute pleasure to introduce our speaker for today's NTF Live session. Jenn Johnson is a wife, mother of two, and a registered nurse in Ontario. She has spent the last 16 years of her career in the emergency room of both large and small hospitals all over northern and southern Ontario. As a nurse in high acuity care, Jenn has personally been a part of the heartbreak, drama, bullying, and life to death moments of dealing with emergencies. And like the rest of us, she struggled to cope, both personally and professionally, during the recent COVID pandemic. Jenn's work is a rally cry to all the other nurses struggling to find their way in nursing without losing their spirit and their love of the profession. Many nurses these days find themselves burnt out, depressed, and feeling challenged as they try to be there for their patients in both mind and heart. Both are critical to making the best decisions for care under extreme and dynamic conditions. Regardless of how nursing has changed for all of us since the pandemic, we still want to show up for our patients, our families, our communities, because they desperately need us. Jenn is here to help you engage your inner knowledge, the kind of knowledge that'll help you make the right decision at the right time and ground that decision in a symphony of information that's sourced from the connection between your heart, your head, and your hands. So now let's talk about building your intuitive knowledge base. Take it away, Jenn.
Oh my God, Judy, thank you so much for that introduction. Oh my gosh, craziness. So, I'm Jenn. I'm an ER nurse of over 17 years now, and it's been chaotic to say the least. But what I've found is that nursing intuition, we talk about this at 3 a.m. when we're kind of going back and forth and we're telling each other stories. The theme of trust your gut is one that you'll hear constantly, but we all kind of shy away from it for just a little bit, just because it's evidence-based, what's going on. And I'm pleasantly surprised to tell you that there is so much evidence on not just intuition, but specifically intuition in nursing. Over the last 9 months alone, I think there was like roughly 700, 800 studies that were published. So please know that while this is a very personal feeling, it is also highly sourced and highly supported by the evidence. So just going through the objectives. Oh my gosh, let me minimize that. So the objectives, just defining what intuitive knowing is and its role and how it can affect clinical decision making. We're going to identify some moments in practice when intuitive knowledge has influenced care. We're going to differentiate between fear-based reactions and intuitive insights, as well as practice a simple evidence-based informed activity to strengthen our intuitive awareness. So I want everybody just to close your eyes and try this activity with me. So when you close your eyes and I ask you about when was the last time your gut told you something, what comes to mind? Was it you were at school and there was an answer on a quiz that you just knew? Was it you were walking home from the bar and you had an uneasy feeling about somebody behind you? Just try and think, when was last time that your gut screamed at you that something was wrong? And so keeping that in mind, if nothing else, please remember that there were over 2,600 articles on nursing intuition in the last 8 months alone. Sorry, that was as of August of this year. Multiple validated tools incorporate nursing intuition into their scales and relating to predicting patient deterioration. So think of the Nurse Intuition Patient Deterioration Scale, the NIPDS, as well as the Rothman Index. So these are ways that algorithms are actually being built into charting systems and are taking the nurse's intuitive insights into account when incorporating kind of an early warning scale. You do know more than you realize, so it's really time that we start to trust ourselves And critical care nurses are more likely to use their intuition for the simple fact that they just don't have any time to second guess themselves and talk themselves out of it. So, what is intuition? Intuition has been described as a gut feeling, and just a knowing. Sometimes it will be an idea pops into your head or a question pops into your head, and you're not quite sure where it's coming from, but you want to instinctively trust it. For many of us, many females, we know this feeling intimately, but it usually relates to our personal safety and our survival in many instances. So, again, if you've been at a party or you've been out to a bar and you see somebody across the room and you're just like, I'm just not sure why, but I don't like the vibe. I don't like something about it. Just there's something off. And when it comes to our own personal safety, we don't second guess that. We just go with it. So we need to start taking those kind of strengths and insights and bring them into our clinical practice. So Merriam-Webster's dictionary defines intuition as the power or faculty of attaining to direct knowledge or cognition without evidence of rational thought and interference. So it's just very quick and ready insight, and you're not quite sure where it's coming from. It's also can be defined as heuristics. So heuristics are mental shortcuts that we use to make very quick decisions, especially when dealing with very complex problems and especially in very time limited environments. It's just that very quick snap judgment that we decide to go with. So making sure that they serve as guidelines, enabling us to make informed decisions more efficiently. And then essentially heuristics helps us simplify decision-making processes and reducing cognitive load, so that we can, make kind of a snap judgment and go with that instead of being caught up in falling down the rabbit hole of, well, what happens if I do this or that or this, and you kind of just get stuck. So this way, this is a very quick way that your brain just goes, nope, we're just making a snap decision and we're going to go with it. Just as a note, heuristics and intuition can be influenced by bias. So just being aware that we all have cognitive biases about, certain situations, genders, ethnic backgrounds. Just being able to be very frank and honest with yourself about scenarios when something's happening. Just, yes, I can make a snap decision, but just be very, very cognizant that sometimes our biases do play into it. So just as a caveat. So the 5 ways of knowing in nursing. So empirical knowing is formally expressed through facts, models, and theories. These are the hard facts, so vital signs. Aesthetic knowing, the art of nursing is achieved with empathy and is dynamic with adaptations and understanding of the components as a whole. So this is kind of more the art of nursing. Personal knowledge enables the nurse to identify his or her own responses and strengths through response strengths and weaknesses in any given situation. So being aware again of personal bias that may affect the nurse-patient relationship. How has your previous work impacted your current day-to-day interactions? So, you've had an interaction with somebody before where maybe you've gotten assaulted or hurt. That is going to tinge how you approach every other scenario that's familiar or similar in that way moving forward. Ethical knowledge focuses on the moral components of nursing practice and tries to answer the questions of what is right and what is wrong. And this is more like your internal compass. And the anticipatory and emancipatory emancipatory knowing is the 5th pattern of knowing, the capacity for someone to be aware of the societal culture and political situation of society and what's surrounding them, and to critically reflect on these issues, being aware of the disparities within where you're working, the communities that you're working in, the communities and the different types of populations that you're working with, and then being able to do something about it. So the science behind intuition. So a lot of this can be attributed to kind of pattern recognition. So we are unconsciously detecting patterns from previous experience. This rapid processing allows us for fast and instinctive decisions before the full clinical evidence is available. And it's really tied to more expert level practice. And the more experience you get, the more exposure you get to clinical scenarios, obviously, then you're more able to connect the dots with previous situations and then one that's right in front of you. I've seen this before, and the patient's going to crash. When there is a senior nurse who is kind of very hesitant about a situation or a scenario, please believe them. We've had some experience. We've been exposed to some really random things at times, and so when somebody gets to be very unusually cautious when it comes to something that you don't think is such a big deal, um, know that that's because they've probably had a bad outcome previously. So, myself included, ectopic pregnancies scare the living bejesus out of me, and so does pancreatitis. So, they seem, if I was to say that during the ER, nobody would really say much about it. But knowing that that's my history, I'm going to be extra vigilant when those types of scenarios arise. So, in the neurobiology of intuition, intuition involves an interplay between the prefrontal cortex, your judgment, and the amygdala, which is your emotions, and then the gut brain axis. So, you feel like there's a knot in your stomach, a heaviness, twinge. You're just like, ugh, something feels off when you're entering a room, and then you're sensing that something is wrong. So, again, this person may not have done anything, overtly said anything, come at you with any aggressive gestures, but there's just something that when you walk in the door, you're going, I'm not sure about this clinical scenario. I'm going to be extra careful. This also revolves around emotional intelligence. So, high emotional intelligence supports accurate intuition by helping nurses tune us into emotional cues from our patients, being able to read patients as we walk in. Is somebody kind of crouching down, not making eye contact, heads down, turned away? Maybe they're with somebody. And you're getting the story from the patient as they're coming in to emerge, and the story isn't matching the injuries, or there's something about the story that you're just not sure about. And when you look at the interplay between one person, the patient, and whoever is accompanying them, maybe there's more to this, especially with domestic violence, human trafficking. You need to be extra cautious as to being able to very quickly kind of read the scenario and read your patients without them saying a word. This also allows us to manage personal stress and emotional overload, which, let's be real, nursing is nothing but emotional and personal stress and emotional overload. So getting comfortable with being overloaded just a little bit allows you to kind of get, okay, I'm not overwhelmed because of the stress. I'm overwhelmed because there's more to this scenario than I realize that's what's going on. This also allows us to navigate complex interpersonal situations, again, like the domestic violence and human trafficking. We like to think that this doesn't happen in our communities because we're Canadian and we're nice and we're good people. Unfortunately, you can't just assume that everybody's doing the right thing all the time. So please be very aware that when your gut is telling you that the story doesn't match the scenario or the story doesn't match the injuries, please listen to it. Worst comes to worst, if you offer help to somebody and they say, no, I'm safe at home, or no, I'm not in this scenario, I'm fine, I would rather be wrong than have missed that opportunity. It's just a personal thing. Emotional intelligence sharpens awareness of unspoken needs or duress. So, recognizing a patient's anxiety despite them saying that they're fine. So, again, watching for all those very subtle cues, body language, curling in, curling away, trying to make themselves shrink, letting the person that they're with do all the talking for them. That's kind of a red flag. So, activity. So, if everybody's got pen and paper, I will give everybody just a hot minute to grab some. We're just going to kind of figure out what you think about your intuition and where you think it's coming from and where you think it's going. So, we're just going to bridge intuition and the evidence. So I'd like to present you with a scenario. So this is Mr. Smith, a 68-year-old gentleman who is admitted with pancreatitis. He's a chronic alcoholic who's had many past admissions over the last decade for the exact same issue. And he is past the period for withdrawal, so he's out of the alcohol withdrawal period, and has been admitted for the past several days at this point. He's pink, warm and dry, and his resps are free and easy. You go in to assess him and you're doing your head to toe. It's first thing in the morning. He seems alert and oriented. His vitals are all within normal limits, but he suddenly grabs his abdomen and doubles over in pain. So we're just going to take a minute. How's your gut feeling? Are you worried about this patient? Are you not? Are you thinking that something's wrong? You know, obviously you want to do a little bit more investigations, but in this exact moment, are you worried that it's a life or death? And if you all want to use your little thumbs up button, um, is everybody good if I move on? All right. So his vitals were, sorry, this was this was made for US. So the temp was 98. So temp's 36.5, heart rate's 87, rest rate 16, SpO2 was 96, BP 146 on 87. Pain was just 2 out of 10. After he's then now doubled over, his temp is still 36.5. Heart rate's now spiked a little bit to 98. Rest rates are up a bit at 19. SpO2 is at 96. BP is at 130 on 71, but his pain's now 5 out of 10. How's your gut? Do you feel like anything's kind of sounding off, like really trying to grab you? Or are you just like, well, we'll just kind of keep an eye on it and see how it goes? Would you notify the doc? And again, this is just one point where it's just a very quick check in with yourself. Um, you know, it's 2 a.m. Are you coming to grab the doc, or are you just going to kind of watch and see what happens? So usually at this point, most people are just, kind of keeping an eye out. Maybe some would call for some pain medication if the patient didn't already have some, but we're just kind of watching. So an hour goes by, and you now have an extra moment to go back and check in on Mr. Smith and repeat his vitals after you've given some Tylenol for the pain. So his vitals were 36.5, heart rate 98, rest rate 19, SpO2 96, BP 130 on 71, and pain was 5 out of 10. Temp's now up a little bit at like 37. Heart rate is now 102, rest rate's 19, SpO2 is 95, BP 119 on 63, but pain's 1 out of 10. Would you notify the doc? Or are these expected outcomes for what you're doing? You've given some Tylenol, pain's down, seems pretty straightforward. I personally probably wouldn't notify the doc. But how's your gut? Is it twinging a little? Is it kind of kicking up a bit? Or are you feeling like, no, I actually feel better now because now the pain's managed? So 2 more hours go by. So 3 hours since you've come on, and you've gotten really busy with the rest of your assignment. You're running around. Everybody needs everything: water, more pain meds, the whole bit. You pop your head back into the patient's room, and he looks comfortable, but he's now a bit pale and almost a little waxen. So his vitals were temp of 37, heart rate 102, rest rate 19, SpO2 95, BP 119 on 63, and pain was 1 out of 10. So temp's now 38, heart rate's up to 112, rest rate's 23, O2's 94, and BP's 101 on 56, but his pain's 0. Now would you notify the MD? And what is your gut telling you to do? Are you feeling better? Are you feeling worse? Unchanged? Or do you start to feel like something is kicking up? So now you've notified the doc because you've recognized that the patient's starting to deteriorate. But you were put off by the doc. The doc states that she knows the patient. She's said that his lipase levels have been significantly higher on previous admissions. She's not concerned, and she hangs up on you. Not the best, but it happens. So his vitals were temp at 38, heart rate 112, rest rate 23, O2 94, BP 101 on 56, and pain 0. You chart everything and are more suspicious now than ever that the patient is not going to do well. What's your gut feeling like? If you close your eyes, take a lean back, and just check in with yourself. Is there any heaviness in your chest? Is your gut starting to feel a little nauseous or feel heavy? Is there questions kind of spinning around in your head? What's going on? So this was my patient, and this is adorable little me way back in 2008. But this was my patient. And I mean, years go by, and unfortunately, he deteriorated further. Within the next hour, hour and a half, he was on pressors to keep his blood pressure up because his blood pressure bottomed out. He was even more febrile. His heart rate was out of control. His oxygen levels decreased. And within about 2 more hours, we were doing chest compressions and continued chest compressions for, I want to say, like 20 minutes or so before calling it. And I don't know if you decided to call the doc at every single opportunity, but I did as a new grad. I must have called 2 or 3 times. I got a little bit of Tylenol. I got a little bit of bolus at one point. But I got put off and I got put off and I got put off and I got put off. And it wasn't until I left that job 5 years later where that doc pulled me aside and said, don't let them tell you that you don't know what you're doing, and walked off. And we really had never spoken about that patient since. But I knew exactly in that moment what she was talking about. And it just really upset me that I floundered for 5 years thinking about, did I do enough? Did I call enough? Did I let that patient down? Was that on me? And just going on like that. Judy, what's up?
Jen, I was wondering in the PM on the
Yep.
postmortem, what did you find out happened? And did it what was going on for you?
So we didn't do one. We didn't do a debrief. We didn't do a postmortem. The doc who was on was also the part-time coroner, so there wasn't even an autopsy. What I think happened looking back now is I think he perfed his bowel, and I think it was because of the pancreatitis that he perfed his bowel and then went septic. Um, that's the only thing that kind of makes sense at this time. But that's 5 years of my very early career where I constantly questioned what I was doing and, could I have done more? So, if nothing else, intuition is simply advocacy. And so, when you go to your docs and you say, hey, I'm just advocating for my patient that I don't think they're doing too well. And I think something's going on, but I'm not sure. That is a completely valid statement. Saying that you think that something's going on, but you're just not sure what, completely valid. I personally will tailor how I approach my docs depending on who it is, how long I've known them. Do we have kind of a casual relationship? Or are they quite formal? It's not like I'm going up to my docs and saying, hey, my patient in bed 3 really isn't doing too well. My intuition is saying that something's going to go wrong. That's not what I'm usually saying. Usually when I'm going up to my doc, it's, hey, the lady in bed 3 is really not doing too well. I think something's going on. Could you just come and have a second look? And again, if you get put off, just say, okay, well, that's fine. I'm just advocating for my patient, because truly you are just advocating. And once you throw that word around, people stop and people listen. It's not a word we typically use in conversation, especially while caring for our patients. Um, but if you have a physician who you think really needs to see your patient, you can just say, well, that's okay. I'm just telling you that I'm advocating for my patient, and I'm just gonna, chart as that's what I'm doing, because that is what you're doing. Um, but just know that that is a completely valid way to talk to your physicians. Judy?
Yeah, I think that's a really good point, Jen. And I just wanted to offer that sometimes when I'm feeling like something's really wrong, but the physician and again, these individuals are human beings, right?
Yep.
They be thinking about something that's gone on in their house,
Oh,
or
for sure.
about a different patient. But yeah, I like Shannon's comment. Sometimes I'll repeat back to them. So you're not concerned about this. When
Hmm.
concerned, and when would you want me to call you back? I think
Perfect.
I love this. So you're not concerned because you're really
Yes.
them. That's what you're hearing. But Shannon, honestly, I've added to that and I've said, I will be documenting. everything that I feel and saw and
Hmm.
uh, said to you. So,
Yes.
you sure that that's the decision that you want to make? And
Yep.
not threatening. That's just reality.
No.
I'm going to do. So you do have options. Thanks, Shannon,
Hmm.
in there.
Thank you, Shannon. Yeah, it's the same thing, right? Where some the physicians are just as, able to make errors as we are, right? Everybody's human. Everybody's got a million things going on. Everybody's got a home life. Everybody's got craziness at work. And again, their head might not be in the right space. So again, that's another great way to say, like, hey, I'm just double checking. Like, you're actually hearing me, correct? Like, things you are hearing that I'm concerned about my patient, and I'm just covering my behind by telling you. And again, chart, chart, chart. Um, Whatever you chart in the patient's chart, just write it as if you're going to be reading it out in court. It's probably one of the best pieces of advice I've ever gotten. Thankfully, I haven't been to court due to a patient scenario just yet, but with the ER, it's always a possibility. So just whatever you chart, again, make sure it is professional, it is accurate, and you are conveying your concern. People will know with my charting, especially if I'm really mad at the doc, if I'm putting the doc's name into the charting. I have notified, provide, Dr. Smith at this time, no new orders received. Any nurse who is reading a chart who reads no new orders received knows exactly what that means. It means I have advocated for my patient. I was told to kind of sit on it, and I'm concerned. So you can always chart that no new orders were received. And that lets the chart know, that lets, potentially legal know that if they were to go through the chart again to be like, no, I advocated, I got nothing back in return. So just know that that is also an option. So, how to advocate. We talk about SBAR quite a bit, and it's a really great way to kind of summarize things for people who are new and kind of getting in and are not sure how to present things to the docs, or even your charge nurse if you're really concerned. So S is for situation, so just what's happening right now. B is the background. What's the clinical background or context of what's going on with that patient? What's your assessment? What do you think the problem is? And then, excuse me, R is recommendation. What do you recommend or need? Sometimes newer nurses are a little bit hesitant to suggest a recommendation because they may be unsure themselves. But again, this is a collaborative approach with your physicians, that everybody is working together. There is no one person higher than the next. Everybody is working together for the best outcomes of the patient. So if you think about it, with our last scenario. So, hi, I'm calling about Mr. Smith. I'm concerned that he's having a change in his vital signs. He was recently admitted for pancreatitis, but we're out of the alcoholic withdrawal window. Um, I'm seeing, here's my, you list the vital signs. Pain is this. I'm looking for either pain medication, maybe a bolus, or maybe I just need to for you to come in and see that patient. So just the act of having the doctor reassess your patient improves patient outcomes, even if nothing has changed. And this is a study from 2008. So pretend that you are the new nurse. You've got a concern about your patient. You get the doc to come and see them. Even if the patient, or even if the physician comes to see that patient and they change nothing, the patient isn't as sick as you thought that they were, you're still learning kind of what sick, not sick, really sick looks like. This is a way for the doc to have a touch point on that patient, even if they change nothing, no new orders received. The doc is happy with the patient in that condition. The patient outcomes will still improve, even if they don't change anything. So really, there is no downside to being somebody who advocates for your patient and kind of going above and beyond a little bit. Um, I've done it where I thought maybe the patient wasn't doing as well as they should have been, and maybe I'm missing something. I grab my doc, I say, hey, can you just come and have another peek at this patient? They don't change anything, and I'm like, okay, well, I would rather be wrong and have you see that patient and be on and err on the side of caution than to have talked myself out of getting you to see that patient and then potentially have an adverse outcome. So just know that again, the science is behind you in advocating for your patient. Judy?
Jen, that's a really good point, and I just wanted to also share with the new grads in the audience that that's a really hard thing to do as
Yeah.
a new grad, because you don't have that sense of confidence. And if someone says to you that they think that your assessment is not a good assessment, or they give you a sense that you're not okay, that can cause you to really back away in future
Yep.
situations. So I think what I would also suggest is just grab a colleague of
Yep.
yours and a more senior colleague like Jen and say, okay, I just want to run something by you. I don't expect you to go to the doc. I will go to the
Yep.
doc. Just want to
Yep.
know that I'm going with something solid. So don't forget
Yeah.
that other people to reach out to.
Yeah. Your coworkers, your charge nurse, again, if you're just a little bit hesitant, you're just like, I'm just not sure. The number of times we run things by each other is constant. I'm still running things by my other colleagues, hey, I know that the doc is busy. Can you just come and see Mr. Peterson? Like, I just don't know, like, if this is does he look, sweaty to you? Does he feel cold? Like, what do you think? And honestly, there is no more powerful question to pose to people than what do you think? Because it kind of does play on the ego a little bit. Everybody likes to be asked their opinion and to have an opinion about something. So please do not shy away from asking for a little bit of extra input because again, if you're concerned about somebody and then you also bring it to your charge nurse and then the charge nurse goes, holy cow, oh yeah, no, we need to like get on this now. Perfect. Now you've been validated. You are on the exact right path. And now you're advocating for your patient again, and things hopefully will be improving. So, 3 ways to strengthen your intuition. Reflecting often is key. So, if you can try and keep a journal, how did things go today? Was there a patient who I thought, maybe the story didn't really match up with the injuries? Was there more of a past medical history that maybe they had forgotten about? Or, did I sense that there was something more to the disease process that was going on than what originally was thought, or something changing and now the patient had been stable for days and days and now unfortunately something is changing, because never assume that the patient isn't going to deteriorate, because that is exactly, unfortunately, the second you will get caught with your pants down. And it is not pleasant to lose a patient, and then to question whether or not you had any hand in that or not. I'll tell you from personal experience, it is not nice. And if I can help any one of you avoid that guilt or that second thought for a lifetime, I will happily do that. So reflecting often, especially when you have a win, especially when, yep, you know what, I thought something was kind of going wrong. I wasn't 100% sure, but I got my charge nurse, I got my doc, yeah, and they changed things. The antibiotics got changed, or we increased the level of care, or now there was just this happenstance that the patient was admitted for one thing and now they're a diabetic and all of a sudden now their sugars are out of control even though they're admitted for COVID or something like that. um, things can change while patients seem stable. So just be cautious. Trust your body's signals. So when that heaviness in your gut, when you feel off, when you feel like you've got questions racing around in your head about potentially what's happened or the situation that you're in, please listen to them. And please, 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 please speak up, especially when it's uncomfortable, because no matter what, it will be uncomfortable for the first few years until you really get your bearings as to, what sick, not sick, really sick looks like. It's going to take some time. You think that you've seen really sick up until all of a sudden somebody else comes in and, oh my gosh, that is really sick. Now I've got a new benchmark for what really sick looks like. So yeah, just speaking up, especially when it's uncomfortable, is probably one of the things that has kept me out of a lot of really sticky situations. But it took time. It's not like it happens instantaneously. So I will open it up to questions, and I will kind of put my put my stuff back up so I can actually see you guys because I'm much better with seeing people than, than not. Oh my gosh, let's stop sharing. Hey, there we go. Oh my gosh.
Well, that was
Oh my gosh.
fab.
And
That was
oh
fab.
my gosh.
Thank you.
Thank you.
Thank you so much for that. Oftentimes, people put questions into the chat. There aren't any currently, but we certainly welcome. I've got the full.
Yes, please.
So anyone who has a question, maybe put their hand up. That would be super. I did want to comment. I love your never assume things will continue to be stable. That I
Yes.
always are like hoping they'll continue to be stable, but always being open to a change in whatever which is why we round so often on our patients because things can change.
Yeah.
And
Yeah.
listening to the patients, right? They'll be also telling you something just doesn't feel right. And then you can go there in terms
Hmm.
of clinical evidence. And if you don't find it, but at least you're listening to them because they know their bodies and they know their situations. But it
Yeah.
all comes down to trust, doesn't it, Jen?
Trust and experience. Like that's kind of the main thing of all of it. So it's hard and a lot of us who've gotten comfortable and being experienced, oh, the patient knows their body. Oh, okay, well, so myself, so I had cholestasis in pregnancy and had it with both my kids, and it wasn't until was pregnant with my second and I knew that the relative likelihood of me getting it again was 70 to 90%. So I'm like, okay, I'm kind of on the lookout for this. And it wasn't until I think about 28 weeks, when normally it's not caught till about 36, 38 weeks. And I just, I remember thinking something is wrong. It's not like I'm in pain. It's not like I'm uncomfortable. It's not like something's catastrophic, but I just had this overwhelming feeling of something is wrong. And so, sure enough, had my bile salts checked again, and they were already elevated at that point. So, it was again another lesson to myself to remember that yes, the patients do know their body's best. If a patient is telling you that they're dying or they're going to die, please believe them. You would not believe the number of times that a patient has said to me, I'm going to die, and they do. It is disconcerting at the very least, but there is something about they just have this overwhelming sense of doom. And if nothing else, it cues you up to be extra cautious. You make sure that, maybe they need another ECG, maybe they need more monitoring, maybe they need another set of eyes. And again, if you go to your doc and say, hey, my patient is saying that they are going to die, if your doc has got worth their pound of salt, they're going to come because they've been in the exact same scenarios where patient has said this and then they've coded.
Yeah, I've had those situations myself, Jen, and whenever I hear that, or whenever I did hear it when I was in practice, it was always something I responded to.
Yeah.
There's a comment here. New nurses often recognize later signs of clinical status change, investing in
Yeah.
your intuition through reflection and confirming with colleagues allows you to recognize early signs.
Yeah.
What Yeah, and this is a good question. If anybody's willing to, any of the new people in the audience are willing, or whoever, willing to say,
Yeah.
do you recall a situation where an early sign turned out to be something that turned out to be a challenge for the patient? Is anybody willing to offer another experience other than Jen and myself? I know we've got some senior people in the audience as well. Any new grads that would be willing to share their thoughts on experiences or situations that they've been in that have spoke to them about their intuition, whether it was like, oh yeah, I was bang on there, or no, I
Yeah.
wasn't. And that helped me understand that it's not always going to happen that way. Anybody willing
Yeah.
to share? You don't expect you to share, but it's wonderful if you can.
I'll just interject just a little bit. So my favorite charting line is all of 7 words. Patient pink, warm and dry, resps, free and easy. If that's all you chart every 4 hours, that lets everybody know, again, reading the chart, that person was alive and breathing at that point. But it also gives you a little tweak to say, okay, was the patient cool, clammy? and resps were kind of agonal, that's a problem. Or if one of those, 6 things changes, okay, maybe that's a change then from what I originally saw. So again, it's a nice little way to kind of cue you up to say, oh, the patient's kind of sweaty now, like they're fine, or all of a sudden they're hot to the touch, now they're fevered. It's a great way to kind of cue you up that, oh, something's changing enough that now there's an external sign.
Yeah, I liked this idea of that you spoke about at the very beginning, where the picture of the patient that you're seeing doesn't match the vitals,
Yep.
um, doesn't, or their story doesn't match their clinical evidence. If things don't make sense, it's like there's just something that's not making sense here. That's
Yeah.
essentially your intuition saying that something's wrong and that you should try to speak to that. So,
Yeah.
nurse of 25 years, when a patient says, "I just don't feel right," that gets my mind going. Yeah, absolutely,
Yup.
Tracy. Yeah, and so you're, as Jen said, you're more hyper vigilant, if nothing else. Like, you may not see anything, but you'll probably go check the patient more frequently. You might look back on their chart and get a sense of, I'm missing something. What are
Yeah.
we? So
Yeah.
any
The sleuth may be activated. The sleuth may be activated.
what's the
Oh, like the sleuth, like the detective.
of course. If you'd said Columbo would be activated, I would have known what you're talking about.
Matlock. Matlock's the
Okay. Sure. Great point, Tracy. Anyone else that has comments, please do put them in the chat or put your hand up. Jen, it's been a wonderful, wonderful.
Ugh,
Oh, Jen, Lindsay is asking, how do you keep track of your own body and its signals when you're in a chaotic environment? Great question.
yeah. And that's the ER for me, right? Where it's chaotic, but you start to become very comfortable with the average level of chaos. Because really, it can seem chaotic, but once you kind of get in there, you're like, okay, nobody's actively dying. There's nobody in the department that I'm really worried about, especially as a charge nurse. You go around and check with everybody. Is there anybody that you're concerned about? Because that may not have been conveyed to the charge nurse in the past shift. So I like to go around. And even if you're getting handoff, I always ask, is there anybody in this room that you are concerned about? That you kind of like want extra eyes on, that you're just like, if people are asking you, hey, text me about like what happens with that CT, or like, let me know what happens with that outcome. That's a red flag. If somebody's interested in the outcomes, they are also on the hunt for answers. So be very curious about like, okay, why, and ask them, okay, like why? Like what are you thinking? Again, put it back on them because everybody loves to be asked, especially the ER nurses. We love our egos get a hold of us sometimes. So
Nurse wants to feel connected with that inner knowledge. And
yeah.
another, you could be as straight at handoff as, is there anything that your gut is telling you about this patient? You could
Yeah.
just ask,
Yeah.
or alternatively something like, is, if you were to be concerned about anything related to this patient, what would it be?
Yep. 100%.
It's going to take with you and maybe explore further, or just kind of keep in the back of your mind.
Yeah. But it's hard, trying to kind of check in with yourself. Worst comes to worst, drink lots of water so you have to go pee. So that you have to actually take a step out of the department and give yourself 2 seconds where it's like, okay, how am I feeling? Am I super anxious? Well, am I super anxious because of what's going on in the department? Is it there's a patient that's kind of making me be more anxious? Or is it just I'm picking up on the whole department because we had a code and the family's really upset, and that kind of is affecting me. Being aware that the emotions around you especially will tweak you sometimes and kind of lead you to be extra vigilant. So it's just checking in with yourself, being like, okay, if all of a sudden I'm really upset, well, was I really upset 2 minutes ago before I entered this patient's room? Well, no, but they've just gotten a new cancer diagnosis and they're very obviously very upset. And that's what I'm picking up on. So, okay, 2 minutes ago, I was fine. This is their emotions. I can be empathetic towards it, but I'm choosing not to pick it up myself. So just kind of putting on the little Teflon vest and trying to just know that that is not mine. I don't need to take it. Um, Apply process to your daily, building a routine. Yes, a routine is key. Um, the inevitable surprise is always take 2 minutes at a quiet spot to regroup. Yep. Box breathing, fantastic. Highly, highly recommend box breathing. Um, you won't miss the 2 minutes. Your plan will be much more solid. Exactly. I typically will go in 10, 15 minutes early just because I typically will get a better report if I go in earlier. And then I'm already ahead of the queue when it comes to doing assessments and vitals, and then going for meds. If everybody's getting the meds out of the Pyxis at the exact same time, um, I can I can just kind of be ahead of the curve, and then I don't feel like I'm chasing my tail the whole shift. As a nursing educator teaching nursing students, what would you like me to share with my students who will be new grads regarding nursing intuition? Oh my God, the best piece of your advice. Just listen to yourself and trust yourself. It's okay to be wrong. You're going to be wrong. It takes time. But just listen to yourself. Your body knows more about what's going on than you realize. Judy.
I just wanted to make mention, I tell new grads this all the time because, for them to sort of take time to think about things in these very chaotic environments. And someone mentioned, I think it was Kate, something about going to the bathroom. I tell grads that if you're having a moment or you need a moment, just
Yes.
go to the bathroom because it is perfectly acceptable. You don't have to go to the bathroom. You just have to spend time in the bathroom. Nobody's going to bother you. It's quiet, and it's a very acceptable reason to separate yourself from the situation. So
Yeah.
Elizabeth says, I really like Giselle's question. I'm a nurse counselor. That sounds fascinating.
Ooh.
I don't usually talk about intuition with newly hired nurses, but I now believe it can bring so much to their development. And your talk was very so that,
Oh, Elizabeth, thank you. My gosh.
and maybe that's a really great way for us to close the session. Thank you so much, Jenn, for sharing your expertise and your wisdom and your knowledge. Yeah, thanks, Elizabeth, for that heart. Wanted to remind people that there's information on the evaluation, and the evaluation of the session will include uh, being entered into a draw. You have to put your email in there, but you'll be entered into a draw to win one of Jenn's books. So yeah, thanks so much, Jenn. Getting lots of clap
Anytime. It's good for
feedback.
my ego.
We all need a little bit of a stroke every once in a while. So thanks,
Oh, goodness.
and thanks to everybody. Hope you'll tune in to NTF Live next time.